Good evening, everyone. My name is Bethany Yiser. I'm president of the CURESZ Foundation. CURESS stands for Comprehensive Understanding via Research and Education into Schizophrenia. And I am very pleased tonight to introduce Dr. Jeffrey Strawn. He is an associate professor of psychiatry, pediatrics, and clinical pharmacology at the University of Cincinnati and at Cincinnati Children's Hospital. He's director of the University of Cincinnati Anxiety Disorders Research Program, and he's the Associate Vice Chair of Research in the Department of Psychiatry, Behavioral Neuroscience at UC. Dr. Strawn, thank you for joining us, and the floor is yours.
I am really excited to be here, Bethany. And as you know, anxiety disorders are something that I'm really passionate about. It's something that I got interested in probably in residency, and then that interest kind of continued to evolve from understanding the physiology to understanding treatments and how individual patients respond differently. I guess before we get started talking about anxiety disorders, we probably need to spend a minute talking about anxiety because I think in contemporary times there's a lot of almost conflation of what's anxiety and what's an anxiety disorder. Now, as we know, every single one of us has an internal alarm system that has evolved with us. So when our ancestors heard something rustling in the grass, they needed to relatively quickly decide whether that was a lion or a saber-toothed tiger, or whether that was just the wind. So the alarm, which is fast and loud and automatic, helped us to survive. Now, the issue is that alarm is still very much present in our brains. And we're going to talk a little bit about where that alarm physically resides in the brain, although it's like any alarm system, pretty well wired with the windows and with the doors and with other aspects of the house. Now, we can kind of, in another way, think about it as almost a smoke detector. Now, when it senses threat, whether that threat is me having burned my toast in the toaster, or whether that is actually the house on fire, we get a similar reaction. So we get our muscles tensing up, we get our breathing changing, we get blood shifting from digestion to defense, and we really prepare for this fight or flight reaction. Now, in most folks, this kind of alarm system or the smoke detector is pretty well calibrated. It obviously goes off when we burn toast, but it sometimes goes off if I'm sending an email or if I'm doing something that's relatively normal, like getting on a plane, or if I'm getting ready for a minor meeting or something like that. So what we're going to do is try to talk a little bit about how anxiety kind of became a part of who we are as humans, and then how that sometimes becomes an anxiety disorder. So as we think about anxiety, one of the things that we know is that the anxiety disorders are probably among the most common psychiatric conditions that we have. Now, that's relevant because anxiety disorders are common by themselves, but anxiety disorders oftentimes go along with other conditions. They co-occur with depression, with PTSD, with sleep disorders, with substance use disorders, bipolar disorder, schizophrenia, et cetera, even things like dementia, or what we now call major neurocognitive disorders. Now, when we think about the symptoms of anxiety, we can kind of break them up into two groups. Now, we often think about the anxiety in terms of those thoughts. Am I going to get it right? Am I going to mess something up? What's going to happen next? Am I prepared for this meeting? Am I going to get in a car accident? What's going to happen as I cross this bridge? But many of our patients with anxiety also have a lot of physical symptoms. These include things like restlessness and headaches and sleep problems, but they can also include things like shortness of breath or trouble concentrating. They can include fatigue. They can include muscle tightness, especially in the neck and the shoulders. They can include abdominal symptoms. There's lots of things that go along with this. Now, one of the things that's always important to think about when we think about anxiety disorders, and again, I'm biased here because I'm also a child and adolescent psychiatrist, And so I think about development, and we'll talk a little bit about why that's important. When we look at the anxiety disorders, not only are they the most common among the psychiatric disorders, but they're also among the earliest to emerge. And so when we look at this study, which looked at, this is a European study that actually looked at folks who were followed from birth over time. And what we find is that social anxiety disorder tends to be one of the earliest disorders to actually emerge. And that's followed by uh, things like agoraphobia, which is that tendency to avoid, situations where escape is going to be really difficult. So going to a concert, going to, in some cases, going to school or being in an assembly at school. And then we have things like panic disorder and generalized anxiety disorder. Now, generalized anxiety disorder is kind of the poster child of anxiety disorders because it's really something that's characterized by worry that just goes over and over and over again. A lot of those physical symptoms. It's difficult to control worry. It's a sense of tension. These are patients that will also often have insomnia, especially difficulty falling asleep as opposed to difficulty staying asleep or waking up in the middle of the night. Now, the other reason why it's important to really think seriously about anxiety disorders is because anxiety disorders tend to occur earlier than depression. And that's important because we know that anxiety disorders increase the risk of having a depressive disorder. And so for me as a researcher, if I can think about, is there something that I can do early on in an individual who has an anxiety disorder to prevent or to lower their chance of having a depressive disorder or depression later in life? That's something that's really important to me. Now, I mentioned before that these disorders don't just occur by themselves. So the anxiety disorders often co-occur with other conditions. So when we look at patients with major depression, what we find is that 60 to 70% of them may actually have an anxiety disorder. Similarly, with substance use disorders, it may be almost a third of those patients who have an anxiety disorder. And you can see there for patients with OCD. But here's where it gets really interesting, and it's really important because when we look at non-psychiatric conditions, when we look at things like irritable bowel syndrome, chronic pain, fibromyalgia, what we find is that these are also patients that have a higher incidence of having anxiety disorders. Now that we've talked a little bit about the comorbidity and when these disorders actually emerge, what I want to do is to shift a little bit more so into thinking about how patients respond to our traditional treatments. And I'm not going to spend a lot of time talking about treatment. We're going to go over a couple slides related to treatment later. But what I want to do is just generally talk about how patients do. And I think this is a really important story here. So one of the things that we know is that for patients with anxiety disorders, it often takes a long time to get better. And when we look at our acute trials, so looking at the 8-week trial of a medication or psychotherapy for a patient with anxiety disorder, we know that we get a lot of patients better. But in terms of the number of patients that we get fully better, that is, they're not having any significant symptoms, they're truly in what we would call remission, where the anxiety is not impacting their day-to-day lives, their relationships, things like that. What we find is that those remission rates are really not that great. So barely a third of patients are really hitting that remission criteria. The other thing that I think is really important is that, like many other conditions that we treat, like multiple sclerosis or many other medical conditions, irritable bowel, we often find that patients may have this relapsing remitting course. So they get better and they stay better for a while, but then they may have a recurrence of symptoms. And that seems to be particularly important in terms of the anxiety disorders and in terms of that increased risk that we see related to having depression later on or related to having a substance use disorder later on. So I now want to shift over to treatment, but I'm not, this is not going to be a normal treatment lecture in terms of this medication improves symptoms or this medication doesn't improve symptoms compared to placebo. What I want to do is to talk a little bit about how anxiety in and of itself interfaces with treatment. And we know when we're thinking about medications like antidepressants that there's often a lot of anxiety in terms of what this medication might do, or would it change me as a person, or what side effects might I have? And those are all really important things around which we should be asking questions. But I want to spend some time talking about the way in which we think in an anxiety disorder, or the patterns that people have in terms of thinking, which influence whether or not they're experiencing that hesitation around some of the treatments. So I borrow this approach from one of my really good friends who's a phenomenal psychologist that used to be at the University of Pennsylvania. And she talks about anxiety in terms of three big lies. All right. So, in terms of thinking about the three big lies, the three things that our brain will tell us if we have an anxiety disorder, number one is I will over predict that something negative is going to happen. So, in other words, there can be a dog, over here off to the side, and the dog can be, wagging its tail, it's very cute. It's got its tongue out, it's not showing its teeth. It looks very friendly. But my brain, in terms of the lies, is going to tell me that dog is going to bite. So again, something bad is going to happen, is what my brain will tell me. But it gets worse because not only will I predict a bad outcome, which is lie number one, I will predict something with catastrophic consequences. So not only is the dog going to bite me, it's going to bite me in the neck, right? And the third big lie is that no one is going to be able to help. So I'm in a building. Theoretically, there are a couple other doctors down the hall still, but no one would be able to help me. The dog's owner wouldn't be able to help me, etc. So these lies become that the brain kind of tells us become really important as we go to school. They become important as we have a new experience, but they also become important as we think about starting treatment, including psychotherapy, but often medication as well. So our patients may wonder, is this medication going to take away who I am? Which we can think about in terms of that first thought. What side effects will I have? Notice how the question is worded. So it's what side effects will I have? I expect to have side effects, not necessarily might I have side effects. Or if those side effects are there, would they go away over time? Or is there something that I can do as a physician to address those side effects in terms of changing the dose, in terms of switching to another medication? Another thought that people will often ask about as they're starting medication when I'm beginning it in the treatment of an anxiety disorder is what if I become dependent on this medication? So again, what if something catastrophic happens in terms of an addiction? And that's something that maybe we can talk a little bit about in the discussion. And then the last one is, what if there's a permanent, irreversible side effect that happens later in life, or something that comes out, after even the medication is stopped? So these things are so important for us to ask about as patients, but they're also very important for us to think about as clinicians. Now that we've talked about the thinking pattern, I want you guys to hold this in your mind for a moment, because what I want to do now is to talk a little bit about how anxiety, if you will, maintains itself. So how kind of this alarm system actually works. And so we often, from a psychological standpoint, think about it in terms of a cycle. And that cycle includes two parts. It includes anxiety, and it also includes avoidance. So when we have a new opportunity or a challenge, patients may get anxious about that. And that's normal to have a little bit of anxiety, maybe before you raise your hand in class, or even looking at the camera on a Zoom meeting such as this. But what happens that's different in terms of someone with anxiety oftentimes is that there's an opportunity to escape or avoid the anxiety. Now, that's good and bad. Number one, what happens is when I am anxious about going to work and I don't go to work, well, that temporarily lowers my anxiety. But the problem is that now sets the stage for something that's worse, which is I've now negatively reinforced that behavior or that action that I did in not going to work and my anxiety feeling better. It now makes it more difficult to go to work the next day or to engage in whatever it was the next day. So you see this cycle where we kind of have this feed forward process wherein things really can get worse. Now, one of the things that everyone talks about is CBT, right? Raise your hand if you've heard of CBT, right? Everybody says that they get cognitive behavioral therapy. The problem is when we talk about anxiety disorders, there are often relatively few patients that are getting what we call high quality CBT. So in terms of really having what we would call is the exposure component. So we have this thing called exposures, and we're going to talk a little bit more about that because it's something that's really important. What that is it's a way of actually doing something in the appointment that causes a little bit of anxiety. So this sounds really weird because we actually want our patient to be a little bit anxious in the office during one of those exposures. In the same sense that you may get a little bit more tired if you're working out, or your muscles may be a little bit more sore after you work out or after you have a really good run. So things that we like to ask are, how often do you do exposures if you're in treatment for anxiety and getting cognitive behavioral therapy? Who else is involved? Does your spouse or your family member or your parents, do they help with these types of things that you're supposed to be doing outside? By the way, these don't have to be difficult. These can be things like if you're going through McDonald's and you're with your partner, you do the ordering when you pull up to the drive-through, and you're not using the app to order when you go into Chick-fil-A or to McDonald's. All right. So in terms of what we do in therapy, these are not necessarily that difficult. And we like to think of ourselves as therapists, as almost coaches kind of in the moment in terms of helping to explain this process that you've now just gone through and how to kind of incorporate the lies or the things that our brain tells us when we're having anxiety. The other thing that's important for us as therapists when we're working with patients is what we're also doing is we're trying to model that exposure is really a lifestyle and that it doesn't necessarily cause distress per se. So we talked about line number 3, which was the idea that I'm not going to be able to cope with whatever happens. So what we want to do is to actually have our patient experience a little bit of anxiety and then not have that bad thing happen, right? Where they expect to have a panic attack. Because what we're doing there is we're doing something that in our fancy terms we call violation of expectation. So if I think that if I go into Starbucks and I order my coffee, I know that the barista is going to laugh at me. I know that he's gonna, think I'm dumb or, judge me for having modified my drink order or whatever else. And that doesn't happen. The barista's nice and they say, hey, here's your drink, everything, have a great day. What happens is I violated that expectation that something bad is going to happen. And that seems to be the really important way in which change happens in anxiety disorders. So the other thing that we often hear therapists say is that I don't want my patient to get anxious, right? I'm a therapist and we want patients to feel better. That is absolutely true. But the issue is that we need to have a little bit of anxiety. Now, we don't want our patients to have a panic attack in the office, but we don't want them to not have any anxiety because what we're also doing is we're helping them to tolerate the distress that comes with anxiety or that comes with some of these situations. I wanted to spend a couple minutes kind of talking about the what happens under the hood, what happens actually in the brain. And I only included a couple slides on the biology here, but I think this is something that's really important. So we have some brain structures, and these are brain structures that involve dopamine. And what happens is when I, again, expect something to happen, right? I see a friendly dog, but that dog actually tries to bite me. What happens is that dopamine area in the brain is actually going to slow down in terms of firing. And what that does is that strengthens the memory and helps to essentially, the dopamine is like a yellow highlighter that highlights dogs are dangerous in terms of my brain. But what happens is if I have a positive predictive error, which is exactly what I want to happen in my psychotherapy, is I actually increase that dopamine firing. And what that does is that actually erases things. So now I can modify that belief in terms of recognizing that not all dogs are dangerous. Does that make sense? Yeah. All right. One more neurobiology slide. Can I do that, Bethany? Is that okay? One more? All right. All right. We all hear about the
Absolutely. Go
amygdala.
for it.
All right. I was hoping you would say that. So the amygdala is kind of the battery in that smoke detector that we were talking about earlier. It's actually probably more than the battery. It's like the battery plus the circuit board. It really orchestrates and kind of drives that anxiety signal. Now, what we know is that most of our treatments, and by the way, I'm not just talking about medication, I'm also thinking about things like therapy, tend to actually decrease that amygdala activity. They also help to strengthen that relationship between the cortex of the brain, the part that does the thinking, and that lower portion of the brain that includes the amygdala. So let's kind of go back to this dog example here. So we often think about this mismatch between what I expected to happen and what actually happened. So if we think about this again as I know the dog is going to bite, right? This is what I think all dogs are going to do. But now I'm pairing that experience with with a dog that again is, sitting there. It's not, barking. He's got his tongue hanging out. He wants to lick me. He's super friendly, wagging the tail. Over time, what will happen is that I'm delinking that idea of the dog will bite me from the reality. And over time, my brain is essentially wrestling with and modifying that previously held belief. Now, what happens in terms of psychotherapy is that we've created this mismatch between a high expectation of something bad happening, danger, and what actually happens. And when this process actually happens best, it's when the patient has a high expectation that something bad is going to happen. So this learning, if you will, happens best when outcomes are really surprising. Now we're going to switch over from more of the therapy piece to a little bit more of the medication piece. But there's a twist because I'm not just talking about medication, I'm talking about placebo. And this is a really cool study that was just published a couple of years ago. And what they did was they looked at what happens just under baseline situations. So no medicine involved. The patient has an expectation that something bad is going to happen. I have high fear, my amygdala is in overdrive, and I am avoiding even thinking about the dog. Now, when the patients were given a pill, which by the way was a placebo, but they thought it was an anti-anxiety medication, they also had an expectation that the pill would make me feel better. So what happened when in that scenario? What happened was that thinking part of the brain became more engaged. And so now patients are more willing to actually approach the dog or the situation that causes anxiety. And as a consequence, fear begins to reduce. So what actually happens over time is that there's a reinforcing approach to this behavior. Now, I want to talk about something that we often think about, which is different sometimes from bipolar disorder or schizophrenia or even things like dementia. Because oftentimes when we're thinking about anxiety, we know that we can treat with medication or we can treat with psychotherapy. And so there becomes this question of, well, which should I start with? Should I start with psychotherapy or should I start with medication? And unfortunately, we really don't have trials where they've looked at patients that started with one treatment or started with another and then switched. But there's a study that or an analysis that we did of a large study that was done a number of years ago. And this is a child and adolescent study, but I think it has some really important lessons. So in this study, there were a number of patients who received cognitive behavioral therapy. And what we did was to look at those patients that had not gotten completely better with cognitive behavioral therapy. Um, Now, over time, what happened is they were followed and they had the opportunity to add medication if they were still kind of not in remission. So these are patients, just to remind everyone, who've gotten 12 weeks of really, really good weekly psychotherapy, but they've still not crossed the finish line. And now they have this opportunity to add medication. What we found was that there were very, very, very few patients who actually didn't get to remission and were willing to start a medication. And I think that's important because one of the things that we learned here is that number one, actually, in those patients that did start a medication, they got significantly better. The other thing that I think is important here is that there may be an aspect of giving up if you don't get treatment right at the get-go. And so this is where I think, again, and this is probably something that generalizes to lots of things that we treat. If somebody is really giving it their all, they're taking a medicine every single day, they're doing therapy every week, and they're still not getting better, I worry about this aspect of patients and their families giving up and then being less likely to try something else or to switch gears. Now, I mentioned that we would talk a little bit about treatment of anxiety disorders, and I did promise you early on that this would not be this medication beats placebo, this one doesn't beat placebo, this one takes this long to work, or going through all of the individual studies, of which there are many. What I did want to do is to talk a little bit about what we currently have that's available that is evidence-based. And so one of the things that we know is that the SSRIs, so those are the selective serotonin reuptake inhibitors, several of them are approved for treatment of anxiety disorders, and they do seem to improve symptoms over time, as do the SNRIs. So those would be things like duloxetine, venlafaxine, maybe even things like vortioxetine. Now, the benzodiazepines, and these would be things like alprazolam or Xanax, clonazepam or Klonopin, Valium or diazepam. Those are medications that work very, very quickly. But the issue is that in the long term, they can actually have some significant baggage. And so, because of that reason, we don't tend to use them as first line treatments. They used to be first line treatments before we had things like the SSRIs or SNRIs. Now, for patients that don't fully respond, we do have other medication options. Some of these are approved in Europe for the treatment of anxiety disorders. Some are also approved in the US for treatment of anxiety or related disorders. And obviously, these are medications that do have studies that support their efficacy, but we tend not to use them as the first line treatments. Partly because of just the fact that we have a lot of evidence for the SSRIs and the SNRIs as the first line treatments. Now, I wanted to spend a couple of minutes talking about kind of some newer things, because one of the things that really is an issue in terms of the anxiety disorders is that we haven't really had any new treatments that have been approved by the Food and Drug Administration since 2007. So coming up on almost 20 years since we've actually had something approved for the treatment of anxiety. Now, that being said, there are a lot of things that people do try, and we can definitely hopefully have a good discussion in terms of those things. So these include things like CBD. There are a lot of folks that have tried uh, medical cannabis. Really not great evidence there, and actually, quite frankly, may worsen things in the long term. Then there are some other treatments that have been investigated that have unfortunately failed. So they've not shown benefit in terms of placebo. I wanted to talk about one new one, which is receiving a lot of attention. And this is a treatment that's not approved, it's not available. And in terms of disclosure, this is a treatment where we're doing some of the studies here at the University of Cincinnati. But it's actually a compound, which everyone has heard of, called LSD. And it's been, this is not what was used and kind of cooked in people's basements in the 1960s and 70s. But it's something that, you know, has now been explored in the medical literature, and it's part of a group of medications that are called psychedelics. And one of the things that I wanted to mention in terms of these is the fact that they seem to work in a very different way than do our SSRIs or SNRIs or even our traditional cognitive behavioral therapy. And so one of the things that we know is that the lysergide actually activates a specific receptor. It's called the serotonin 2A receptor. And in fact, the same receptor that is activated by a number of our medications that we use for antipsychotics and also mood stabilizers, things like quetiapine or Seroquel, Risperdal, Risperidone, even clozapine or Clozaril. And what happens is this is given as a single dose. And what it does is it helps to kind of loosen up some of the way in which different areas of the brain are connected. And this was a preliminary study, but it was an important one. It was actually published in the top journal that we have in medicine, which not many psychiatry studies actually get published there. So I wanted to just mention it again because it does use a very different mechanism. One of the things that we've often had in the treatment of anxiety disorders is kind of another SSRI, another SSRI, another SNRI, another benzodiazepine-like medication. So this is something that, if it is replicated in additional trials, may be helpful. And there you see kind of the improvement relative to placebo, which actually happened pretty quickly and was pretty sustained. So as we wrap up here and move into hopefully what'll be a really fun discussion, I wanted to just emphasize where we are. So we've talked about the anxiety disorders being very, very common. We've talked about them being chronic. And then most importantly, I think we've talked about the fact that these disorders often overlap with other conditions. They overlap with depression. They overlap with schizophrenia. They overlap with bipolar disorder. And in almost all of these conditions, pairing an anxiety disorder with another disorder tends to really worsen outcomes. We've talked a bit about the fear cycle and avoidance and the way that that kind of maintains symptoms and the way that we actually target that in many of our psychotherapies that we use for the successful treatment of anxiety. We talked a little bit about the medications that we commonly use, at least the first line ones. Those are the SSRIs and the SNRIs. And then we talked a little bit about some of the novel therapies. Again, some of these have shown a little bit of promise, but again, they right now are investigational, and I'm certainly not recommending any of these right now. We just don't have the level of evidence that we needed. And then most importantly, again, just to hit this one more time, really when we're treating anxiety, whether you're kind of treating it, you know, yourselves or working with a family member or a neighbor or a colleague, it really is about exposure. And when I talk with our residents and with our fellows, what I try to do, because they say, how would I do an exposure in somebody that worries about everything all the time? What I tend to do is to actually encourage them to ask the patient, What does the anxiety sabotage for you? What does it get in the way of? What does it stop you from doing? And that is what I go after in terms of my exposure. And then most importantly, it's okay to, if our patients become anxious, it's okay if we become anxious in an appointment. In fact, that's actually a good thing. And then the last thing that I'd mention here, before we move into hopefully some nice questions and answers and discussion, is almost a public service announcement. We hear a lot of people say, "I'm anxious." It's important to remember that that is different from an anxiety disorder. And one of the things that I worry about is, we hear statistics in the news media, 20% of patients or 20% of individuals have anxiety. That's okay. In fact, I hope it's 100% of people that have anxiety, because having anxiety is normal. It's part of being a human. I hope that we all had anxiety before we got behind the wheel of a car the first time, before we took our driver's test, the first time that we, had to read out loud in fourth or fifth grade. We want to have anxiety. It motivates us to be on time. It motivates us to study. It motivates us to try to do a good job at work. So if someone comes in my office and they say, "I want to not be anxious," I say, "I'm sorry. I want you to still be anxious. I don't want your anxiety to interfere with your relationships, with your work, with having fun, but I want you to still be able to have anxiety. If I wanted you to not have anxiety, I would give you general anesthesia and you wouldn't have any anxiety, but that wouldn't be a good life that allows you to still drive and enjoy things and have meaningful relationships." So with that, maybe we can hopefully move into some questions here.